Good morning, respected Emeritus Chairperson Sir, Dr. M.L. Sharma Sir, Vice Chancellor Dr. Zakariya Sir, Pro Vice Chancellor Dr. V.K. Kapoor Sir, Medical Director Dr. S.S. Eswa Sir, distinguished faculty members, my seniors, my colleagues, and dear residents. I, Dr. Ajay Meena, Associate Professor, Department of CTVS, welcome you all in the clinical combined round of Department of CTVS. Before we start the case, I will briefly introduce our department in front of the august gathering of MGUMST family. Our department was established in 2012 and we have 1 MCS seats and department runs in 2 units. Unit 2 is headed by me and Unit 1 is headed by Dr. M.H.C. Sir, and he is the head of department. Our unit runs into units. Unit 1 is headed by Dr. M.H.C. Sir, and he is also the HOD of department. Unit 2 is headed by me, and we have 1 senior resident, Dr. Hussainur Rehman, who has recently joined us. Our department has 3 modular CTVS OT with all latest equipment. We have 16 bedded ICU 1 that is with 8 bed with all latest monitor, including with all invasive and non-invasive monitoring. And we have some special equipment for our CTVS OT like IABP that is used for in poor LV function patients. It reduces the afterload and improves the left ventricle function and improves the it helps in the recovery of the patients. We have 2 cardiopulmonary bypass machine, 1 temperature control machine during the cardiopulmonary bypass. We have latest Philips TE machine, and we have cell saver. In patient with excessive bleeding, this cell saver helps in reducing the multiple transfusion. It works on the principle of auto transfusion. It separates the RBCs and we can transfuse it again in the patient from the after filtering and washing the blood. We run continuous education program where we teach our nursing staff. We take twice a month classes. Our doctors, including cardiac anesthesia team and CTVS team, we are taking regular classes of our nursing staff, and we are also awarding them for best performer of the staff. Department has already done the historic. Department has done the first heart transplant of the Rajasthan in August 2015, and again in 2024 August we have done the first awake bypass surgery of Rajasthan. Our cardiac transplant patient Suraj Bhan has completed his 10-year post-transplant period. In world literature, that post-transplant 50-year survival, 10-year survival is just 50% post-transplant patient. It is always a privilege to receive some award from a medical association and being invited as a faculty member in national level conferences. Coming on to the status of the department, our department has performed 499 cases in 2022. There is a slight dip in the 2023, but in last 1 year we have picked up the cases and we have performed 617 cases in last 1 year in 2024. In last 1 year, 4,206 patients visited our OPD. We have admitted 730 patients, operated 617 patients, and overall mortality in our department was just 2.2%, which is way better than any international center, any international cardiac center. We are performing all kind of CABG, off pump, on pump, total arterial bypass, all mitral valve replacement, aortic valve replacement, double valve replacement, combined procedures, aortic aneurysm surgery, whether it's type A dissection, type B dissection, arch aneurysm, thoracic surgery including lobectomy, pneumonectomy, decortication, all kind of vascular surgery, axillofemoral, ortobifemoral, FEMPOP, axillofemoral, and some congenital cases also. In last 6 months, we are focusing mainly on minimal invasive cardiac surgery, and we are promoting this program. Whenever there is a possibility of doing minimal invasive cardiac surgery, we are performing these cases. This is the case-wise data of last 1 year. We have performed 304 CABG, 150 valve cases, combined cases 20, vascular 50 cases, and aortic aneurysm surgery 27 cases were performed in last 1 year. We are doing complex coronary surgeries including endarterectomy. We have performed 21 cases including LAD endarterectomy and RC endarterectomy, which is very few center in Rajasthan is performing. We have done 38 minimal invasive cardiac surgery cases, and we have done some complex redo wall procedure also. Coming on to the aortic aneurysm surgery, in 2022 we have performed 12 cases of aortic aneurysm surgery, 23 we have done 5, and in last 1 year we have done 27 cases of aortic aneurysm surgery, and most of them were type A dissection or ascending aortic aneurysm with severe AR. The major contribution is from emergency department, where they are without any delay, without any wastage of time, they are referring the patient to CTVS department. Sir, apart from increasing the number of cases in the department CTVS, our major plan for this year is to develop the heart transplant program as a routine, and we are working on it for last 4 months, and we are ready to do transplant, and we are waiting for donor, and we are planning to shift to minimal invasive cardiac surgery program, more cases in the minimal surgery program.
Good morning all. I'm Dr. Hussainur Rehman, Senior Resident of CTVS. Thanks for providing me this opportunity of presenting a clinical case today. The case is of a sudden onset chest pain with breathlessness in a 27-year-old male patient. The patient is a 27-year-old Hindu male patient from Alwar, Rajasthan. He presented to us with chief complaints of sudden onset of chest pain since 4 days and shortness of breath since 4 days. His history of present illness was that he was apparently doing all right 4 days back. He developed mild to moderate gait of retroesternal chest pain, which was sudden in onset, non-progressive chest pain, and it was not radiating to other part. This was associated with sudden onset of dyspnea, which was progressive and present even during the rest. So according to the New York Heart Association criteria, this falls into the class 4. There was no history of fever, sore throat, peripheral edema, joint pain, or any skin rashes. The patient was initially admitted at a nearby hospital where he was managed with IV antibiotics for 3 days, but the patient's condition over the time deteriorated and he had no relief. So he was referred to our center for further evaluation and management. The past history of the patient is that he has no history of type 2 diabetes mellitus, hypertension, bronchial asthma, or any kind of tuberculosis. He is not a known case of any allergic condition. His family history is that he doesn't have any history of cardiac or respiratory disease in his family lineage, and social history is he is a student with middle class family background, and there is no history of smoking, alcoholism, or any kind of drug abuse. So we seen that patient and examined that patient. The patient had a height of 175 centimeters, a weight of 72 kgs, and we calculated the BMI. It was 23.5 kg per meter square. On general examination, we find that the patient was having anxious look, but he was conscious and well oriented. His heart rate was 124 beats per minute, which was regular in rhythm, had a good volume without any radial or radiofemoral delay. His blood pressure was taken in the right upper arm in supine position, and it was 136 by 48 millimeters of mercury. His respiratory rate was 34 per minute and abdominal thoracic in nature. His room air saturation was slightly low. It was 90% at room air, and he was given 2 liters of oxygen support, and the saturation over the time built up to 98%. His temperature was taken in auxiliary temperature was taken. It was 98.6 Fahrenheit. His JVP was raised. On a further examination, we noted that he had no anemia, jaundice, cyanosis, clubbing, peripheral edema, or lymphadenopathy. Then we examined the patient further. On systemic examination, the cardiovascular system, on inspection we found that there was the pericardium was normal without any visible pulsation. On palpation, the apex beat was diffuse and hyperdynamic in nature. There was a thrill present over the left parasternal region at the second intercostal space. On auscultation, we found a very harsh, continuous grade 4 murmur in the second intercostal space on the left side of the parasternal region, and the murmur was fixed. There was no change with respiration. Next, we examined the respiratory system. On inspection, the chest overall appeared normal. There was no scar marks. There was no engorged blood veins. Bilaterally symmetrical chest movement was seen. On palpation and percussion, we note that the overall chest was non-tender. The trachea was central, and chest was bilaterally symmetrical with adequate chest expansion. The normal tympanic percussion node was heard all over the chest. On auscultation, the vesicular breath sound was present with additional coarse crepitations, which was more appreciated in the basal region with respect to apical part. The per abdominal examination, we found that the patient has had a scaphoid abdomen with central umbilicus. There was no scar or engorged vein over the abdomen. It was soft and non-tender. There was no hepatosplenomegaly or any other palpable lump or mass. It was tympanic and the bowel sound was normal. On neurovascular examination, we found that he had normal power in all the 4 upper limbs, and there was no other focal neurological deficit. So overall, the case summary, if you summarize this case, we had a patient of 27-year-old male who had episode of sudden onset chest pain and dyspnea since 4 days, which was of NYHA class 4. On examination part, he had sinus or tachycardia, tachypnea, low oxygen saturation at room air, and raised JVP. There was coarse crepitation on the bilateral lung field, and continuous murmur with thrill was present in the left parasternal region. So, since we have a summarized case, so I want to ask the audience that if they have any kind of possible diagnosis in their mind till now, and if any PG students are willing to answer. So what we had in our mind, the possible diagnosis, we had very differential diagnosis in our mind. The cardiac causes that we had in our mind is that the patient may had an acute coronary syndrome, or he had acute dissection, aortic dissection, or pulmonary embolism, VSD with aortic regurgitation, a ruptured sinus or Valsalva, AP window or the aortopulmonary window, infective endocarditis. From the pulmonary side, we had pneumothorax, pneumonia, ARDS in our mind. So we proceeded with these differential diagnosis, and then we proceeded for the investigation. So first of all, we did the routine blood investigations. We sent a CBC sample.
Sorry.
Yes, sir.
With a harsh murmur in the left parasternal area,
yes,
is
sir.
acute coronary syndrome the first differential diagnosis?
No, sir. But
you mentioned that.
Sir, but chest pain with murmur may be present in.
That is what I am asking.
Yes, sir.
A harsh, continuous murmur in the left parasternal area in second intercostal space. Is acute coronary syndrome the first diagnosis?
No, sir. The differential of the chest pain, one of the differential.
You are saying possible. Now we have taken the history and examined the patient.
Yes, sir.
If you had said this before examination, I would have agreed.
Yes, sir.
But now you know that there is a murmur.
Sir, in some mechanical complication of CAD, when there is a ventricular rupture, the shunt, if it is from left to right, a harsh murmur may be present, but sir, we have to rule it out with further investigation.
Yeah, and how would you explain the clinical syndrome with pulmonary causes? I don't think they should be kept in the DD.
Sir,
there is obviously a leak from the arterial system and acute heart failure. So those conditions should have been upfront, no? Like, see, if you had put acute coronary syndrome with acute MR, then maybe, but I think the sequence and some of the, I mean, how would infective endocarditis explain the clinical syndrome? We're not talking about investigations just now.
Sir, infective endocarditis may present with acute valvular regions also, sir. So in that case, murmur may be. Is
this a hyperdynamic state?
Sir?
Is this a hyperdynamic state?
Yes, sir, this was a hyperdynamic
So
state.
why not think about thyrotoxicosis?
Sir, on other systemic examination, we can go for differential, we can go for thyrotoxicosis, and others, like even we can suspect trauma also. Yes, sir.
Diastolic BP कितना था इसका?
Sir, diastolic BP was 48.
Is that significant somewhere?
Yes, sir. The widened pulse pressure is seen.
Summary, we did not mention that.
I have said this earlier also. There is a difference between what are the possible causes, which is what you write in the theory paper. When you are discussing a case, you have to discuss the probabilities. The most probable diagnosis based on history and examination has to be mentioned first.
I think if we take a general thing as a provisional and a differential, even for the after the history based should be, I mean at this stage should be a provisional and then the differential.
Yes, sir. So after this, we proceeded to investigate the patient further. On blood investigation, we found that the hemoglobin was 12.7 grams per deciliter, and the total leukocyte count was 12,400 per deciliter, with a neutrophil 72% and a lymphocyte of 10%. And the platelet count was 2.6 lakhs per deciliter. His LFT was the serum total bilirubin 1.4 milligrams per dl, and SGPT, SGOT was 166 and 154 units per liter respectively. The renal function test, the serum urea and creatinine was 42 and 1.0 milligrams per dl, and his viral markers were negative. Then we did an ECG of that patient. Here we have shown the ECG. So the ECG finding that the patient is having sinus tachycardia of a heart rate of around 122 beats per minute. We did a chest X-ray of the patient. In the chest X-ray of the patient, we see prominent bronchovascular markings with cardiomegaly present, with enlarged right atrium as we have shown here, with dilated right ventricle with a right ventricular type of apex, and an enlarged pulmonary artery. Following that, we proceeded for echocardiographic examination. For that, we took help from our cardiology colleagues. I want to invite Dr. Zakariya, senior resident of cardiology department.
Thank you, panel. Thank you for joining us. I'm Dr. Zakariya, and we'll discuss about. Okay, thank you. And we'll discuss about 2D echo finding of rupture of this case. So 2D echo finding is our imaging modality for initial diagnosis. It generally real-time visualization of aortic root anatomy, the integrity of aortic sinuses, and will tell the location and pathway of ruptured jet, and the chamber volumes and the function of left ventricle and right ventricle. So in this transesophageal echocardiography, it is more detailed evaluation, but transthoracic is typically first line. So we can see the 4 views of 2D echo cardiography. First is parasternal long axis view. Parasternal long axis view, generally we kept the probe at 3rd or 4th intercostal space of patient. The pointer should be on right side of the shoulder, and parasternal long axis view will tell about the aortic root area and the left atrium and interventricular septum area, and will tell about the abnormality, any outpouching for sinus of Valsalva. The second is parasternal short axis view. Parasternal short axis view we kept at 3rd or 4th intercostal space probe, but rotate the pointer towards the shoulder and at 90 degree. So it generally tells about the coronary origin and sinus of Valsalva. The next is apical 4 view. Apical 4 view is basically on apex of heart, 4th or 5th intercostal space, and will tell all 4 chambers or abnormal flow from right ventricle and right atrium if rupture tract is present. The last is subcostal area. Subcostal area will tell about pericardial effusion. Generally, subcostal area we kept the probe at xiphoid process below 2 to 3 centimeter. And the color and spectral Doppler correlation. The color Doppler is it generally detects high velocity jet from sinus to the receiving chamber. It helps confirm direction and severity of flow. Now we have 2 modes, continuous wave Doppler and pulse wave Doppler. Continuous wave Doppler generally used for high flow velocities, and pulse wave Doppler generally at specific point of depth. So it measures peak velocity and pressure gradient of the abnormal flow, and pulse wave Doppler precisely localize the site of flow, and pulse wave Doppler is generally basically for low velocity area. Identifying a continuous or diastolic systolic flow pattern, it can confirm presence or fistula communication. So you can see the image, the the jet area in between the aortic root. This image, this is left atrium and this is left ventricle. So it's the jet passing from the aortic root to the right ventricle outflow tract. Okay. So this is all about echocardiography.
What is the name of the patient?
So patient 27 में Hindu patient.
Name on this slide.
This is क्या कहते हैं parasternal long axis view, sir.
No.
Yes.
Name of the patient should be there in Mahatma Gandhi Hospital.
It could be anybody's picture.
Can be anybody's picture.
We usually hide the identity of the patient.
But you can write Mahatma Gandhi Hospital. Will stop. Otherwise, it shows that it is from the textbook or from.
Sure. Thank you. Okay. So Todico finding of this case, there will be aneurysmal dilatation of the sinuses. There are three sinuses: right coronary sinuses, non-coronary, and cusp. Sorry, this is cusp. Left coronary cusp. So aneurysmal dilatation of the sinus, it bulge near the aortic root, right coronary sinuses from the right coronary artery. The rupture site will call a windsock. I generally explain the windsock will projecting into the right ventricle outflow tract. It is protruding into the right ventricle outflow tract. We will see the shunt visualization, abnormal jet from the aorta to the right ventricle outflow tract, and the color flow arising on a color Doppler. There will be a trivial AR on this case. The right heart enlargement, because a jet projecting into the aortic root to the right ventricle, there will be a right ventricular enlargement, there will be right ventricular overload that will cause right heart enlargement. There will be dilated mean pulmonary artery. So in this case, this rupture sinus of Valsalva, this is 1 centimeter and it projects to right ventricle that I explained. The jet area from the aortic root to the projects into the right ventricle. There will be dilated RA and RB. Generally, it will cause right heart enlargement. And the other finding is trivial AR and moderate TR. There will be subaortic VSD. Subaortic VSD, it's generally aortic root, aortic root, aneurysmal aortic root dilatation. Position will be 1 o'clock position. The other finding is dilated mean pulmonary artery is 3.5 centimeter. Normally is 2.7 centimeter in female and 2.9 centimeter in male. The IVC is dilated 2.1 centimeter and collapsing more than 50%. There will be AF around 50% and no RWMS present. So my echo part is generally over, and I will hand over the Hussain sir for next of the part.
Thank you, Dr. Zakariya. So after we had this echo finding, we after this echo finding, sir, we can now cross off the other diagnosis that we have and proceed towards our final diagnosis. Now, how did you cross out the acute coronary syndrome? The things that are negative side of this is the number one, the age of the patient. The patient is relatively young, and the ECG has just one finding, and that was a sinus tachycardia. So acute coronary syndromes, we can negative it out. Acute aortic dissection. Now the dissecting pain is usually very severe in nature, as well as it is of tearing type. This was not present in the patient, number one. And number two, there was no radiofemoral delay that we have observed. And the ascending aorta is usually visible in the echocardiogram. So in the echocardiogram also, we didn't find any kind of aneurysm or any kind of dissection. So we can negate this diagnosis also. Pulmonary embolism we can also negate out of this echocardiographical findings. Infective endocarditis, sir, there was no new any acute valvular lesions as well as any mass or fever, so we can negate this finding also. VSD with acute regurgitation, out of the echo report we can say that the AR was not present, the aortic regurgitation was not present, and the AP window we can also negative it out of the echo findings. And the chest X-ray didn't show any signs of pneumothorax, any signs of ARDS or pneumonia. So ultimately we reached to a diagnosis of ruptured sinus of Valsalva aneurysm. In short form we call it as RSOV. So what we had in our mind when we had this final diagnosis, that this is a left to right shunt at aorta to right ventricular level. Being very precise, the aortic sinus to right ventricular outflow tract. It was associated with a VSD which was restrictive in nature, and severe PH was also found.
Any evidence of cyanosis?
No sir, there was no cyanosis.
Usually in the shunt, the cyanosis should be there, no?
No sir, in this shunt we shouldn't expect cyanosis. Cyanosis is usually present live to left shunt where there is a mixing of blood. Here the mixing of blood is from the aorta to PA side.
Left to right?
Left to right will not give cyanosis. When it is right to left, then there will be cyanosis.
Okay. So giving a brief introduction about this condition, first of all we have to understand what is sinus of Valsalva. Now sinus of Valsalva are the three pouches which are seen in the aortic region. If I show here, this is the opened up aorta.
Just use the cursor as a point.
Sir, the cursor is not showing up there. Okay. So this is the diagram of a opened up aorta. If we open the aorta, these are the three cusps or the valve leaflet. So behind that valve leaflet, you can see three pouch-like structures. These are called as the sinus of Valsalva. If you take a section like this, these are the two leaflets. The third leaflet is cut out. As you can see here, these are the three shapes of the leaflet. But if we cut the aorta transversely, we can see that there are pouch-like structures behind this leaflet. These structures are called the sinus of Valsalva. Now, what is the importance of the sinus of Valsalva? There are two primary importance. Number one, that this provides a space between the coronary and the aortic valve, so that there is a continuation of the flow even when the valve is open. And number two, there is something called as eddy current or the Venturi effect, because there is a rotation of the blood within that sinuses. There is a negative pressure which helps the valve to open with minimal resistance. So why this structure has aneurysm? This aneurysm is because of the two primary factors. Number one, this is a transition zone where the aortic media of the aorta joins the media of the left ventricle. So naturally that is an weak area which is present in everyone, but in few individuals, because of the sheer difference in the force, the flow from the left ventricle towards the aorta is very laminar. But when it comes down and hits that valve leaflet again, there is an oscillatory shear force which are very prominent in that area. Because of that, over the time, in few individuals, those sinuses outpouch, and out of that outpouching, even in rare cases, there is a huge aneurysm which comes, as you can see in the diagram C. So thus this aneurysm is formed. So what is this rupture of sinus Valsalva or aneurysm disease? As you can see here, this is a cut section of the heart. So this is the aortic valve. So these are the three cusps or the leaflet of the valve, and the star marks area are the sinuses. The diagrammatic representation is so. So over the period of time, if there is an aneurysm, these can open into these areas of the heart. Now, if you see, the aorta is surrounded by the other structure of the heart, like there is the RVOT or the right ventricular outflow tract, there is left atria, there is right atrium, and the right atrial appendix. So if there is outpouching in this area, and if it is opening within the heart, it will open into the right ventricular outflow tract. Similarly, if there is outpouching here, so it will open into the right atrium. If the outpouching is from the left cusp, there will be flow to the left atrium. So even if there is an opening in this area, it doesn't mean that it will open in only one chamber. It can open in any one of these chambers. After that, we had a definitive diagnosis, and the treatment of this patient is purely surgical. So we had to take the anesthesia consent, anesthesia pre-operative workup for that, and for that we took the help of our anesthesia colleague, and that part will be explained by Abhinav sir. He is a senior resident of anesthesia department, cardiac anesthesia department. Now he will be presenting.
All residents, when I say all, I mean all, bold capital, underlined, italics, should know how to generate a laser pointer, all teachers also.
I'm really sorry for the logistic problem, sir. This is Dr. Abhinav, Senior Resident Department of Cardiac Anesthesiology, and I thank the chair and the system to give me this opportunity to present my views and my management of the patient, a young patient, 27 years old, who presented to us with sudden onset of dyspnea, chest pain, and had tachypnea, tachycardia, and hypoxemia when he presented to the hospital. So, and it was already diagnosed as a case of ruptured sinus of Valsalva when the patient was referred to me. So where exactly anesthesia team settle in here? So for any case which has to be taken for surgery, an anesthesia management can be divided broadly into three parts. The first part is the pre-operative optimization of the patient. Now what do we mean by pre-operative optimization? So it is a set of medical management and medical therapies that are given to a patient who are planned for a surgical procedure, which can improve the condition of the patient so that we can get the maximum out of the proposed surgical procedure. If properly done, a proper pre-operative optimization can convert an emergency case into an urgent case and an urgent surgery into an elective surgery. So this is a role of a optimum pre-optimization for any patient. Second part of a cardiac anesthesiologist in this case is to manage the intraoperative sedation and analgesia in the patient, hemodynamic management while the surgeons are operating over the definitive problem of the disease, and then guide the surgical team with our expertise in intraoperatively transesophageal echocardiography. And the third part is once the surgery has been done, we take care of the patient in the post-operative course in the ICU. So the first part is pre-operative optimization. As my colleague has just informed, the patient is already a diagnosed case of ruptured sinus of Valsalva. So as an anesthetist, I take home two very important parts from this. First of all, because of the shunt, the blood is leaking from the left side of the system or the systemic circulation towards the right side of the system, that is the pulmonary circulation. So there are high chances of hypotension in these patients. Although our patient did not have hypotension because it was a compensated state and the heart actually compensated the hypotension by tachycardia. And the second thing which is important in these patients, that the blood is actually flowing out of the left system towards the right system or the pulmonary system, which is supported by the right ventricle. Now, as we all know, the left heart is actually a thick wall structure which supports a pressure of nearly 120 mmHg, while the right heart actually thin wall structure which only supports a pressure of 20 mmHg. So when extra fluid goes from the left side of the heart to the right side of the heart, it causes problems. It causes problems in two ways. First of all, there is extra fluid in the lung, the pulmonary circulation. So the oxygen exchange is hampered. The patient presents with hypoxemia. As our patient presented with a saturation of 89 to 90 on room here, it was because of excess of fluid which was into the lung and the pulmonary circulation, which was not allowing the oxygen exchange to take place appropriately. And secondly, once the right heart pulmonary circulation is overloaded with fluid, the right heart has to work against this extra pressure. The afterload of the right heart is increased, and slowly and definitely the right heart has to work increasingly, and slowly right heart dysfunction takes place. It has been posted in medical literature that in neglected cases, even right heart failure has been seen in these patients, and in mechanical support system have to be started in these patients. Luckily, our patient was not that much neglected. So as a preoperative optimization of this patient, I had to maintain the oxygenation of the patient because the patient had a saturation of 88-89% on room air. This can be done by giving supplemental oxygen by nasal prongs, face mask, and if the patient does not improve with these maneuvers, we can use bidirectional positive pressure airway, which is commonly known as the BiPAP machine. If the patient is actually sick, we have to intubate the patient, take him on mechanical ventilator. Our patient improved with only 2 liters of oxygen. He was a very early stage and the decompensation has not taken place and the patient improved. The second part of the point is the patient may have hypotension because the left side of the circulation is throwing out the volume towards the right side of the circulation. Our patient was actually a compensated picture. The pressures were still in 120 range, although the heart rate was in 120, also 120. The tachycardia was still maintaining the pressures. So we have to take intravascular access. Actually, there is a slide mistake. Intravascular access. So intravascular access can be 2 types. We can take 2 wide bore peripheral cannula, and it actually suffices. Most of the patients improve. But if we can gain a right central venous access, we can actually measure the central venous pressure of the patient. And why is this important? Because we have to resuscitate the patient and fluids are the first choice for resuscitation. But we should also know that lungs are already containing extra water. So if we can be sure that how much fluid can the patient tolerate, this will be a really asset for our team. So if we measure a central venous pressure of these patients and the CVP is less than 8, we are damn sure that the patient will require fluid. And if it's more than 12, we are sure that the patient is already in vascular volume overload and we should not give the patient extra volume. Then to manage the pressure, the other thing we have are drugs, inotropes and vasopressors. Although both the drugs are very good in maintaining the pressures, but in these patients, inotropes like milrinone is the first choice drug, or dobutamine, which can reduce the right heart function, decrease the pulmonary vascular resistance and help us in that case. And a very important part in our patient was the use of diuretics, because the patient has extra fluid in the lung side and hypoxemia is caused because of this and not because of any parenchymal disease of the patient. If we can take out this extra water from the system of the patient's oxygenation, patient's heart rate and patient's anxiety, everything improves by itself. Short of around 40 mg furosemide IV instantly increased the urine output and the patient suddenly started to feel better. 2 liters of supplemental oxygen improved the oxygen to 98%. And then the patient already explained that this is a surgical emergency, so he is very anxietic. So a mild degree of reassurance, anxiolysis and analgesia actually helps a lot in these patients, more than what I can tell you here. Once we have done the pre-operative optimization, the patient has to be shifted to the operation theatre. I just want to tell one thing, that the patient was admitted to us at 3 p.m. nearly in the evening, and it was planned as an emergency case overnight. But because of adequate optimization of this patient we were able to take this patient in the next available elective slot. So the patient actually did well with these optimization therapy. And it's not only that the pressure on the team increases if we take an emergency case, the outcome of the patient actually decreases. So the elective cases have the best outcomes and the emergency cases have the worst outcomes if we compare the outcomes. The intraoperative course, well, it was a patient of hypoxemia, hypotension. However, he maintained well. My role as an anesthetic was to have a smooth induction, avoid sympathetic stimulation. I choose to maintain the anesthesia with a balanced anesthesia care in which we give intravenous drugs as well as inhalational, because all the inhalational agents reduce the pulmonary vascular resistance, decrease the stress on the right heart, so it improves our case. We ventilated the patient with low tidal volumes and low peak and expiratory pressure so that right heart function remains constant. Routine monitorings were used. No PA catheter was required in such a case, first because of the left heart was still functioning well. And intraoperative hemodynamics were kept maintained using fluids, inotropes and vasopressors, as we have already discussed. Now the second part of my role as a cardiac anesthesiologist in such a case is using my expertise with intraoperative transesophageal echocardiography. And there are mainly 6 points in which I assist a surgeon during his procedure using my skill. First of all, it's very simple. I confirm the diagnosis. At times with transthoracic echocardiography, you can land up to wrong diagnosis, because the proximity of the probe of transesophageal echocardiography, I can confirm whether the diagnosis already made was correct or not, and we require that treatment or not. Secondly, additional anatomical assistance which a surgeon may require for his exposure to treatment of this disease, because as we know that there are 3 aortic cusps, and different exposures are required if the aneurysm has been originated from the left cusp or the right cusp. So this anatomical assistance can be provided with the thorough intraoperative transesophageal echocardiography. If or not any associated anomaly is present, this can be diagnosed with a definitive course with this machine. Then once the surgeon has actually closed the defect, we can confirm whether whether there is any residual in this defect or not. Because all these procedures are done using cardiopulmonary bypass machines, or commonly known as heart-lung machines, to come off the heart-lung machine, actually transesophageal echocardiography plays a very important role and help us and guide us whether there is any associated air inside the cavity which can lead to embolization and CVA later on in the patient. And lastly, when we give vasoactive agents like inotropes and vasopressors to the drug, we can actually see the response of the heart to these drugs in live, and we can know if the therapy we are instituting the patient is correct or not. So, keeping it brief,
so this was the image we obtained intraoperatively. So as we can see, this is the left ventricle, this is the right ventricle, and this is the aorta, and this is the aortic valve. And we can see this outpouching in this region. This was actually the aneurysm of the sinus of Valsalva. It is very definitive that this sinus has been formed. But when we put the color Doppler, we can see that the flow of blood is actually from aorta to the right ventricle, which is an abnormal flow. And this confirms that not only there is an aneurysm, it has actually ruptured and causing all these hemodynamic perturbations in the patient. And secondly, assisting my surgeon via the anatomical structures. So when I cut open this image in cross section, so this is aortic valve in cross section, and we can see all the three cusps. This is the right cusp of the aortic valve, this is the non-coronary cusp of the aortic valve, and this is the right cusp of the coronary valve. This is the left cusp. And we can clearly see that the actual rupture of the Valsalva aneurysm has taken from the right coronary cusp, and this is going into not the right ventricle but the right ventricular outflow tract. So in this way, I can assist my surgeon if he has to change any plans of the opening the chest, if he can modify his therapy or in any way so as to obtain the maximum benefit from the procedure. And when we see this is a still image from the same last picture. So this was the jet because of the ruptured sinus of Valsalva. However, there was another jet, and this is actually a communication between the right ventricle and the left ventricle. This is interventricular septum, and there is a defect here. So the patient not only had a ruptured sinus of Valsalva, he had an additional defect of septal defect of ventricle. So the surgeon can be sure that he has to close two defects, because closing just one defect will not solve all the problems. So this is my role, although my role extends into the post-operative period as well, but I'll want Dr. Hussain to continue with his surgical management of the case. And I'm really thankful for giving me this opportunity to tell what actually a cardiac anesthetist does in the operating theater and the preoperative optimization of a sick patient, because everybody just thinks that a surgeon comes and does the miracles and the patient improves. Thank you.
Now the surgical management was planned. This patient was taken up in the OT in a supine position. We opened up the chest midline, and we took that patient on a cardiopulmonary bypass. As we, in a short form, we call it as CPB. As we can see here, this is a very rough diagram. Here we bypass the right heart, we take the venous flow, put it in a chamber, then we oxygenate that blood and put it in the aorta bag, so that we can bypass the entire circulation through the heart. And this is the bypass machine that we use. Now for this purpose, we do a cannulation. We did a aorto bicable cannulation. Aorto means the aortic cannulation for the arterial supply, and bicable means both of the vena cavas for the venous return. As we can see here, these are the intraoperative pictures that we have cannulated. So the intraoperative findings, when we when you open up the aorta, we found that this is a is a windsock, or the defect from the aorta, which is protruding into the right ventricle. And when we pass this forceps, through the aorta, and it's opened up into the right atrial outflow tract through the pulmonary artery. So these are two images. As we can see in the video, this is the defect that we are discussing here. This is the aneurysmal sinus of Valsalva, and that red dot you can see here where this line has been poured, that is the defect. That is the defect which is communicating between the two chambers. And the next video is the forceps that we are passing through the aortic defect, and it is coming out of the pulmonary artery. That means it's crossing the right ventricular outflow tract. Now here is the diagrammatic representation. As we can see here, there are three diagrams. The first diagram, if you come, we can see green arrow which shows the ruptured sinus of Valsalva defect, and the yellow arrow is the VSD defect. Now how do they repair it? We put a patch which closes the right ventricular outflow and it separates it from the sinus of Valsalva. The red arrow shows that patch, and the blue arrow in the next diagram is the patch that closes the ventricular defect. Now the patch, what is the patch we are talking about? The patch is a autologous pericardium which we harvest from the patient itself. We treat it with 0.6% of glutaldehyde, and this patch has a standard term which is called as the fixed autologous pericardial patch. The first patch goes to close the right ventricular outflow, the ruptured sinus of Valsalva, it closes the right ventricular outflow defect, and the second patch closes the VSD defect. The last second diagram is the post-operative diagram. As we can see here, the small patch and the sutures show the area that we have closed. Now these are the echocardiographic differences that we can see from the pre-operative and the post-operative. As in the first image, you can see when we put a color Doppler, there is a flow which is coming from the aorta to the right ventricular outflow tract. But in the second, if you can see that small area where the patch has been placed. So now we can see that earlier there was a flow, but now the flow, the color Doppler doesn't show any flow through that area, and the small outposting is the patch that we have placed. After that, the patient was shifted to the ICU and the post-operative management was started. So the post-operative management is, because the defect has been closed, there is no effective shunting now from that area. So the principle of the management remains the same: to maintain the hemodynamics and maintain a slight negative fluid balance, titrates the inotropic support that we have, and use of diuretics to have a effective negative balance. We have to provide adequate analgesia to the patients, wean off the ventilators and extubate that patient, maintain a minimum drain and a quick mobility of the patient. These are the basic requirements that we have to fulfill. Now the post-operative course was, as we have shifted the patient to CTVS ICU. On the post-operative day 0, the patient was sedated and paralyzed initially on a mechanical ventilation. His inotropic support was dobutamine infusion, which was given at 3 mics per kg per minute. Injection furosemide was given 10 mg twice a day. Injection cefoperazone and salbectam 1.5 grams twice a day. Amikacin 1 gram once a day, and other supportive measures including analgesia was given. The patient was extubated after 6 hours. On the post-operative day 2, the dobutamine was on the same dose, and the IV antibiotics and the oral diuretics was used. Aspirin tablet was added, and supportive medicines were given. Chest physiotherapy was also initiated. On day 3, the dobutamines were tapered down and stopped. The arterial monitoring lines were removed on day 4, and the patient was ambulated, and by the day 6, the patient was discharged. The post-operative X-ray, as you can see, there is a drastic improvement. The lungs fields are now cleared. The cardiac size has also come down, and the post-operative echocardiogram also shows no significant shunting now. The patient has now 2 follow-ups till now, day 7 post-discharge and day 21 post-discharge. The patient is doing well. His wound has healed and he is healthy. He is on aspirin 75 mg once a day, Ramipril 2.5 mg twice a day, and toracimide 5 mg once a day. Now coming to the discussion of this disease, the sinus. Yes, sir.
It was an autologous graft. Why glutaraldehyde?
Sir, we have to fix it. We can use both. Either we can use the unfixed one, and for chambers where there is a huge pressure difference, specifically in the left side or VSD, we use a autologous treated one. For low pressure chambers like ASD or in a pulmonary artery, we use a non-treated one.
And how long will he be on antiplatelet drugs?
Sir, usually we keep patient up to 6 months to 1 year. Then we can switch off that antiplatelet. Now, ruptured sinus of Valsalva is a rare disease which prevalence of only 0.09% in general population, and it is characterized by the abnormal dilatation and rupture of this aortic wall. The patient usually remains asymptomatic till that thing ruptures, and then there is a congestive heart failure, arrhythmia, and even sudden death are reported. Now, the causes are usually congenital and acquired. The rheumatic arthritis, Ehlers-Danlos syndrome, Marfan, Turner's osteogenesis imperfecta are usually associated with the congenital defects, congenital syndromes, and acquired are usually bacterial infections like bacterial infections, syphilis, and TB. Degenerative conditions are also associated with it, trauma, and iatrogenic conditions like presence of hematoma or post AVR, we see this condition. But in our patient, it is idiopathic. The patient has never any other associated syndromes or any other cardiac authorizations before that. The precipitating factors of sinus of Valsalva ruptures are usually weight lifting or sudden straining, trauma, infection, pregnancy, and cardiac intervention. Now, where all it can open, now it has been classified in different categories. We had a type 2 kind of RSOV, which is a right sinus of Valsalva rupturing into the supracrustal area of the ventricle. As we can see here, these are the diagrammatic representation. Our patient has type 2 kind of sinus Valsalva rupture. So this is the right sinus which has been draining into the right ventricular outflow tract. Now the incidence, the overall internationally, if you go through the articles, we can find that the exact incidence is not very well documented. But the studies suggest that the incidence in general population is 0.09%. Male to female ratio is 4:1. So it is more common in males, especially in the Asian populations. As we can see here, the 84% Asians with RSOV present with a right ventricular rupture. The symptoms depend predominantly on the site of the rupture. In our cases, the rupture was into the right ventricle, so increased pulmonary blood flow causes lung congestion and breathlessness. The sudden volume overload leads to symptoms of right ventricular failure, and the incidence of the rupture to the RV side is usually 85%. That has been reported in the Asians. What are the complications that we face? There is heart failure due to acute volume overload leading to congestive heart failure. There can be aortic regurgitation, endocarditis, arrhythmia associated with a thromboembolism, pressure because of the large aneurysm, pressure to the adjoining structures may give some symptoms, and even after repair, there may be recurrence. And why the associated with sudden cardiac death? This is because of the arrhythmias, myocardial infarction, and cardiac tamponade. So what to do in case of such patient arrive, especially it is important for emergency department and cardiology. For unruptured sinus of Valsalva aneurysm, a regular follow-up echo 6 monthly basis is done to track the aneurysm sign and its progression. During that time, beta blockers, ACE inhibitors, and calcium channel blockers are usually given to keep the systemic pressure low and avoid any kind of physical exertion. But if it is a ruptured case, then immediate stabilization followed by a prompt surgery is the norm. So what are the indications of surgeries? As we can see here, if it is a ruptured case, as we have it here, a sudden prompt surgery has been advised. But if it is a stable patient with asymptomatic and unruptured cases, we have to keep a follow-up of around 6 months. But if it extra cardiac extension is there, then also urgent surgery is advised. So the outcome of the repair, the surgical repair is a definitive treatment with a good success rate. The immediate mortality is low, it is less than 5%, usually range between 1.9 to 4.6%, and the overall survival rate up to 15 years is 90%. And what are the recent advances regarding this subject? The recent advances is that in literature and other institutes, they have started doing transcatheter closing, which is a minimal invasive technique and usually indicated for very high risk surgical candidates who are very old age or have comorbidities and not allowing for surgical management, or there is an acute hemodynamic instability leading to emergency closure, and there is no association with other major defects. So the contraindications for transcatheter closure in our case was a large RSOV defect in the aortic end, which was more than 1 centimeter, 10 millimeters, and the juxta-arterial VSD that is present in our case. The other contraindication are associated AR, the RSOV with multiple rupture sites and infective endocarditis. In these cases, we cannot do the transcatheter closure. And the complications of the transcatheter closure is that device that we put it can migrate. There can be hemolysis. Their device can encroach into the aortic leaflet leading to AR. There can be AV conduction blocks because the conduction zone is very near that, and it may compromise the coronary inflow leading to MI. So the take-home message from our side to everyone is that as clinician we must look for uncommon conditions also in very commonly encountered clinical symptoms. Usually we are more focused towards the very common diseases, but we have to keep our minds open for that also. With that, I would like to conclude my presentation. Thank you.